questions. See, if you have a problem with it, I'll have to rearrange it next time, but I've already done certain things. See, basically the way I normally do that is, I know last time, because of time constraint, there was a bit of an issue. You guys didn't know what is going on. Basically, what I normally do is I do a question and then I discuss about that particular topic. If that is not how you guys want it, then what I have to do is I have to talk about the topic and then do the question relevant to that.
We'll go for the questions and then discuss it.
You guys understood what I'm trying to say? Yeah. Go on. Yeah.
You can go with the question, sir, based on which.
But I think there are some new students. That is what she was concerned about. And see, it's not about, see, basically, it's not about solving the question. That is not what why I'm showing the questions. So basically, the questions give an idea how things get asked. For example, if we talk about each topic in nephrology, that itself will take a very, very long time. Like if we talk about glomerulonephritis, that itself will take half an hour, 45 minutes of one session. Okay, because it's more about a refresher about what you read, clearing any doubts. But if you have a certain part of nephrology or certain areas which you're finding it difficult or something like that, you just pass on the information to the team there, and then they can communicate to me which areas you find it quite difficult. Okay, because normally what I'm trying to do is that because each area, there are a lot of, when if you look at nephrology, like if we talk about renal tubular acidosis, like, metabolic alkalosis, etc., each one will be half an hour each, which we won't have time to do all of that. You got that?
Yes, sir.
So I think there's a little bit of confusion. So what I've told the person in charge yesterday is that what I told him is I think he will probably be in touch with you. So I'm not sure how other people do. Everybody does it in a slightly different style. Obviously, everybody is very different the way they teach, etc. But what I was telling him was that if you have any particular thing which is not clear, you can tell me. I can do it a little bit more detailed in the next session or something like that with a few more slides, etc., which makes it a little bit easier for you guys to understand and see. Yeah? Got that? So now what I will do is, because of the way things, I'll just talk a little bit about the topic and do it. If you have a problem with it, just let me know. Okay? Okay. So here, now what I'm going to, my mouse is really playing up. Just 1 second. Yeah. Can you see the slides?
Yes, sir.
Okay.
Yes, sir.
The first topic I'm going to cover is about renal artery stenosis. Okay. So when it comes to renal artery stenosis, you have two things which you need to be bear in mind, particularly when it comes to with regards to exams, etc. One is what we call is a fibromuscular dysplasia that you tend to see in young women who present with resistant hypertension. And one of the causes of resistant hypertension, particularly in young women, is fibromuscular dysplasia. Okay. So here, as you can see it in the picture, there is obviously some narrowing of the renal artery happens because of the what we call is the fibromuscular dysplasia. So these patients can present with resistant hypertension, etc. Generally, what happens is in this condition, the other major differential diagnosis you have is atherosclerotic renal artery stenosis. But that tends to happen in people who are what we call as arteriopaths. So who are diabetic, smokers, elderly people, etc. You are not going to get a younger person developing features of atherosclerotic renal disease. Okay, it will be very, very unusual for someone, say, let's say 20, 30, etc., to present with atherosclerotic renal artery stenosis. Yeah, got it? Okay. Now, so if you have a younger person who's got a history suggestive of renal artery stenosis and has got a severe hypertension, the most likely is going to be fibromuscular dysplasia. Likewise, let's say you have a 60, 70-year-old or a 50, 60-year-old who's a diabetic smoker. I mean, they have risk factor for arterial disease, hypertension, resistant hypertension, particularly features of peripheral vascular disease like renal bruit, femoral bruit, and worsening kidney function, etc. That would indicate that it is more likely to be due to atherosclerotic renal artery stenosis. Okay. Now, the other thing to bear in mind is that generally, the renal function is generally preserved in the setting of fibromuscular dysplasia and hypertension. Whereas in case of atherosclerotic renal artery stenosis, generally there will be renal impairment will be there. Often it will be long-standing renal impairment. It may not be apparent at that time. The other thing to bear in mind is that one of the clinical scenario where you may pick up atherosclerotic renal artery stenosis will be when somebody has been given something like an ACE inhibitor or ARB. Because usually what happens is that when you have renal artery, when you have a compromise to the renal blood flow, the kidney tries to maintain the blood flow by activating angiotensin 2. So you can imagine that if you give somebody an angiotensin 2 inhibitor like ACE inhibitor or angiotensin 2 receptor blocker, that can compromise the kidney flow even more. Okay, so often what the other scenario where you might see in the exam setup is where somebody's got a relatively stable renal function, difficult to control blood pressure, and given an ACE inhibitor or ARB, and the renal function gets worse. See, what you have to remember that is when you give somebody an ACE inhibitor or angiotensin 2 receptor blocker, what often happens is that there will be some reduction in kidney function. That is because of hemodynamic effect. So you can get a reduction in kidney function up to 10 to 15%. That is in terms of the increase in the creatinine or reduction in GFR. Okay. However, if there's reduction in GFR far more than that, that may indicate that that patient could have renal vascular disease or renal artery stenosis. The other thing again, with regards to the exam setup, the one other scenario you need to remember that is rarely a patient with renal artery stenosis can present with flash pulmonary edema. See, basically what happens is that these patients will suddenly come in with breathlessness. The blood pressure will be very high. They will have features of fluid overload. They often have acute kidney injury. However, they are unlikely to have any issue with the cardiac function. So often the cardiac function is either preserved. There is no usual evidence of an acute coronary syndrome or anything like that. But they would have come with pulmonary edema. It could have been triggered by being treatment with ACE inhibitor or angiotensin 2 receptor blocker. Then again, you have to think whether it could be due to atherosclerotic renal stenosis, particularly bilateral renal artery stenosis causing flash pulmonary edema. Does that make sense? Do you understand that?
Okay, sir.
Any questions on
Yes,
this?
sir.
Yeah.
Yes.
Yeah. The only other thing to bear in mind is that if somebody's got a young hypertensive who you're thinking of fibromuscular dysplasia, often the intervention is beneficial. So you may have to go for an angioplasty, a stenting, etc. It will be likely to be beneficial. However, in atherosclerotic renal artery stenosis, except for very selected cases, usually intervention is not beneficial. The selected cases are most likely to be somebody with a single kidney with worsening kidney function. Second will be somebody presenting with bilateral renal artery stenosis and having flash pulmonary edema. Except for those 2 or 3 instances, usually intervention in atherosclerotic renal artery stenosis is unlikely to be beneficial. Yeah?
Yes.
Okay, you got that?
Yes.
Yes, sir.
So that is
Yes, sir.
just 1 second. The Zoom is playing up again. 1 sec. Yeah. Okay. Okay. Now, this is really repeating what I've already discussed, really. So if somebody's got a what we call as a renovascular hypertension, this is what normally happens. So there is activation of renin-angiotensin system. They often will present with features of hypertension being there for a long time, like they may have evidence of left ventricular hypertrophy, some evidence of proteinuria, etc. So generally, as I said to you already, that the one of the 2 instances where you have to bear in mind, particularly in the exam scenario, is somebody has been given an ACE inhibitor or angiotensin 2 receptor blocker, and the kidney function has got worse. And second, a patient presenting with pulmonary edema. A lot of other situations where you may come across it, but generally, it's more unlikely that your treatment is going to benefit or vary a great deal. The only other point I forgotten to mention is that one of the clues where you might see in imaging might be asymmetric kidneys. Okay, so particularly in the setting of renal artery stenosis causing hypertension, renal impairment, etc., what you might see that there might be discrepancy in the kidney size. So, for example, one person can have one kidney measuring about 6 or 7 centimeters and another kidney measuring 9 or 10 centimeters. And usually in nephrology, we regard a difference of more than 2.5 centimeter between the 2 kidneys as clinically significant. Okay, anything less than that is generally not significant, but somebody's got a difference, a discrepancy in kidney size of 2.5 centimeters or more, it would be more suggestive of renal artery stenosis or atherosclerotic renovascular disease. Okay, does that make sense? Yeah.
The one doubt, sir.
Yeah.
For fibromuscular dysplasia, it happens as bilateral disease.
Not necessarily. Can be bilateral or unilateral. Yeah.
So what will be the imaging findings in fibromuscular dysplasia?
You see, I mean, you will see renal artery stenosis only, but they are less likely to have features of other evidence of atherosclerosis. They are not going to have features of atherosclerosis elsewhere or anything like that. As I said, the best way to differentiate will be the age group. See, people are not going to present with fibromuscular dysplasia in their 50s and 60s, etc. Okay. So usually it'll be young hypertensive. Generally, it's a female between the age of 20 and 30 who will present with resistant or severe hypertension.
And we have to do renal angiogram for that.
Correct. Yeah, that's right. I mean, you can do either what is that digital subtraction angiogram of the kidneys, or you can go for particularly if you're worried about, so particularly in this, let's say a patient who has a moderate to severe renal impairment, you are worried about giving an angiogram, obviously the contrast making kidney function worse, then you can go for a MR angiogram as well. Okay. However, again, because you raised the point, I'm just mentioning it again. If there is a question later in the next class, something I'll cover that. It's that, see, contrast, that can give you a contrast nephropathy. MRI contrast is usually not a problem in vast majority of patients with mild to moderate kidney disease. However, in severe kidney disease, even MRI contrast, gadolinium contrast can give you, any guys heard of a particular condition which is due to MRI contrast? Gadolinium-based contrast. Okay, there is a condition called nephrogenic systemic fibrosis, which typically happens because of gadolinium-related contrast accumulation in patients with severe renal impairment undergoing MRI scans. Okay, so you can do an MRI without a contrast as well, just like you do a CT without a contrast. So
Can
that
you
will
repeat the name of the situation, sir?
it's
Can you repeat the name, sir?
systemic fibrosis. I can write it down if you want, just 1 second.
No, sir, I got it, sir. Nephrogenic
Okay.
systemic fibrosis.
Yeah, that's right.
Thank
So
you, sir.
this is, you only see that in patients with generally with severe renal impairment who undergoes MRI contrast media. Having said that, with the newer MRI contrast media, the risk of nephrogenic systemic fibrosis is a lot less. I've not seen someone develop, probably also because we are more cautious, but it is very rare to see that nowadays. In the olden days, when people are not aware of it, we used to do MRIs more frequently in patients with moderate to severe renal impairment. We used to see that a lot more. Nowadays, we don't see that. That is mainly due to accumulation of gadolinium-based, contrast media. Okay.
The MR angio is a diagnostic, sir.
It is. I mean, ideally, you want to do a CT angiogram, but MR angiogram provided the right person who knows how to interpret these things. It is diagnostic. It gives diagnostic information. However, if you definitely want a diagnosis, the best thing is to go for a standard angiogram, peripheral angiogram.
No, I'm a cardiologist, sir. We
Yeah.
do regular MR angio.
Yeah.
And corkscrew renal arteries are more common with fibromuscular dysplasia.
Okay. Yeah. Okay. Yeah. See, obviously, again, with cardiac, when MRI doesn't give all the information you want.
Yes,
No,
sir. Yes, sir. Yes, sir.
Heart. So just like any test, there are always a bit of limitations. If you want a definitive diagnosis, it's better to go for a CT angiogram. But the point is, let's say you're suspecting renal artery stenosis or renal vascular disease. As I've already mentioned, in majority of the people with renal vascular hypertension, the intervention is not beneficial. There are a lot of studies have been done, and all the studies have shown that very few patients benefit from intervention in renal artery stenosis. So often it's more of a diagnostic thing rather than going to be an intervention thing. So here, the MRI is likely to be helpful. You got that?
Yes, sir.
Yeah. Okay. Now, what I will do is, now I'll go back to the question. I know you got that. It's covering whatever I've already discussed really. So here you got somebody, a young woman who's presents with a severe headache. Her blood pressure is very high and it remained high. And she's went to the, outpatient clinic. She's got a bruit in the left side. The kidney function is relatively normal and she's got asymmetric kidneys. Okay, so this is like typically what we discussed just a few minutes back. Yeah. So given the age group, it's unlikely to be atherosclerotic renal artery stenosis. So here, what's the likely diagnosis? Already, some of you mentioned that already.
Fibromuscular stenosis due to fibromuscular dysplasia.
Yeah. So as I said, it's not only about getting the right diagnosis. It's also important to know why it's not the case and why the other diagnosis is not the case. Yeah. Because as I always tell people, the exam, you're not going to get the same question. There will be variations of these sort of similar questions. So it's important to know how you interpret the information given and how you come up to the most likely diagnosis. Often you have to look at other things. So here, pheochromocytoma, they're not really given any features of pheochromocytoma here. Like adrenal crisis, you will get this sweating, palpitations. See, somebody gives information like that. Pheochromocytoma has to be on the top of the list. Atherosclerotic renal vasculitis, we already mentioned. It's likely to be a slightly older person. Often they have features of atherosclerosis elsewhere. They have high risk factors like, smoking, diabetes, peripheral vascular disease, etc. Cons, how will we differentiate?
Hyperkalemia.
Hyperkalemia.
No, it's not hyperkalemia, it's hypokalemia.
Hypokalemia, yes.
Yeah, so you get hypokalemia and what's the other one you will get?
Hypokalemia with hypernatremia with
Metabolic
metabolic
alkalosis.
alkalosis.
That's right. But you have to remember that renal artery stenosis can also give you the same thing because it can give you secondary hyperaldosteronism.
Yes.
Because cons is primary hyperaldosteronism.
Yes.
Yeah. Whereas
Renal-
secondary hyperaldosteronism due to renal
Renin.
artery stenosis can also give you a metabolic alkalosis, hypokalemia. That's why the history is important. Cons is not going to give you an asymmetric kidneys. Yeah.
Yes, sir.
Yeah, so that is how you differentiate. Because again, that's what I'm saying. One of the other causes of metabolic alkalosis with hypokalemia would be Cons syndrome. They've not given the electrolyte disturbances, but renal
Also, the presence of the bruit, which is
yeah,
there.
that's right. True. Yeah, that's right. Bruit also, you are not going to get that. Yeah. Okay. And then Cushing's.
Clinical features.
Symptoms.
Features of
Similar
Cushing.
things, sir.
Yeah. So they would have given
history
other features of
of
Cushing's. Yeah. So they're not
obese
mentioning anything
individuals,
about
right?
obesity, excess hair growth, all those sort. There's nothing has been mentioned. So based on the information we have here,
Hypernatremia.
sorry.
Hypernatremia. In Cushing,
That is not-
hypernatremia also.
Yeah, hypertension will be there. Not necessarily. Again, Cushing's can also have a mild hypokalemia as well. Yeah.
Yeah,
Both
but
hyperkalemia and
hypernatremia.
metabolic alkalosis can
Yeah,
So they have-
hypernatremia will be very unusual actually. Yeah.
So I think hypokalemia and metabolic alkalosis is more both in Cushing's and Cons.
Yeah, Cushing's also can get that, but generally Cushing's patient don't necessarily develop quite severe alkalosis or anything like that. But borderline hypokalemia is often seen in Cushing's. Yeah, just like Addison's will give you hyperkalemia and metabolic acidosis, but Addison's only will rarely give you a severe metabolic acidosis. Yeah. Yeah,
Okay.
got that? Yeah. Okay. So I'm going to skip the next question. Okay. Now, the other question I'm going to talk about in nephrology is probably very common in clinical practice. I've just taken some things from one of the review articles. So basically what you have is you have a situation where you got a patient who's got both renal disease and lung disease. Okay. So that is what we mean by pulmonary renal syndrome. Yeah. And
Yes, sir.
typically in this pulmonary renal syndrome, what happens is that these patients will have evidence of pulmonary involvement, often pulmonary hemorrhage. Yeah. So alveolar hemorrhage. Okay. So often these patients will present with hypoxia, hypoxia, hemoptysis, and by lung infiltrates, which may or may not be present. Not everybody will have a lung infiltrates on the chest X-ray, but they may have a features of hypoxia as well as hemoptysis. And if you got a patient who's got a kidney injury, particularly acute kidney injury, so that what I mean by that is the patient have renal impairment, recent onset renal failure. Sometimes we may not know, and the urine will be active. Do you know what I mean by active urine? Yeah.
Sediment, sir.
Hematuria.
Yeah, that's right. Proteinuria,
Hematuria.
hematuria. Proteinuria and hematuria. Yeah. So if you got a glomerulonephritis, you are going to have usually going to have both proteinuria and hematuria. Yeah. That's what we mean by active urine. So urine is bland, usually mean very unlikely that they got a significant glomerular. Somebody's got you check the urine, there's no protein, no hardly 1 or 2 RBCs. It's unlikely that they got a glomerulonephritis. Yeah. So usually when they have a glomerulonephritis as evidenced by proteinuria, hematuria, hypertension, renal impairment, with presence of lung features like hemoptysis, breathlessness, shortness of breath, etc., you call that as pulmonary renal syndrome. Okay. Got that? And this is like almost
Yes,
like a medical emergency, actually. So because some of these patients can land in serious trouble if we don't treat them promptly. Okay. So when you have something like a pulmonary renal syndrome, there are about 4 or 5 classes of conditions which will give you this sort of finding. What you call is an acute kidney injury with pulmonary hemorrhage. That's what we are talking about, pulmonary renal syndrome. There are some other conditions where you may get some lung involvement, but they don't usually cause pulmonary hemorrhage. Okay. So when you have pulmonary hemorrhage and renal involvement, the two top differential, there are various causes I've listed here, but the two major differential diagnoses is one is ANCA associated vasculitis and second one is anti-GBM disease. Okay. Yeah. You got that?
Yes,
Yes,
sir.
sir.
Yeah. So there are also some of the other
sir.
causes like SLE, etc. But the two major causes should come to your mind. If so you got a patient or a scenario with pulmonary renal syndrome will be ANCA positive vasculitis and anti-GBM disease. Rarely somebody can have both ANCA and anti-GBM, but at least for MRCP setup, it's very unlikely somebody is going to ask you a question on that. So you got ANCA positive vasculitis or anti-GBM disease. And the way you, sometimes it can be very tricky to differentiate. So you may have to wait for your serology, you better wait for kidney biopsy and other information to come through. But one of the ways two ways you can, at least two simple ways one can distinguish is generally anti-GBM disease will come very, very acutely. So usually it will happen over a matter of few days to a week or two, generally in anti-GBM disease. The patients will come and they will get very sick within a matter of days. ANCA positive vasculitis tends to have a lot more systemic symptoms like features of cutaneous vasculitis, features of arthralgia. Often they will have upper airway involvement as well. Yeah. Particularly with the old-fashioned vagus granulomatosis, or we call it as granulomatosis with polyangiitis. Yeah, so they may have an upper airway involvement, etc. However, the true diagnosis is only going to be identified by doing a kidney biopsy. Again, your blood test like ANCA can give you an information, but rarely patients can be ANCA negative as well. Okay, so that's why it's important to go for kidney biopsy in these patients in practical situations. However, with regards to other causes, there are 2 to 3 things you need to bear in mind. And the one important cause is the eosinophilic granulomatosis polyangiitis, and other one is SLE. However, these SLE that eosinophilic granulomatosis, IgA, cryoglobulin, etc. These things are generally very, very rare in terms of causing pulmonary hemorrhage. SLE is very common in exams. SLE will cause you other lung involvement as well, but SLE presenting with pulmonary hemorrhage is generally very rare. Okay, so the most two things, as I remember that you have to think of ANCA positive vasculitis or ANCA negative vasculitis can be there, or anti-GBM disease. And generally, the diagnosis is going to be achieved by doing a kidney biopsy as well as checking ANCA as well as anti-GBM levels. Okay.
Sir,
So,
excuse me.
yeah.
Sir, and in anti-GBM disease, what will be the pulmonary symptoms?
So generally, they will just come in with pulmonary hemorrhage, features of pulmonary hemorrhage. It'll be shortness of breath, hypoxia, and hemoptysis.
Okay, fine.
Yeah, the
Thank
CT
you.
and other things might show infiltrates, etc. But clinically, it's very difficult to distinguish ANCA from anti-GBM disease or any other cause of pulmonary hemorrhage because they're all going to come with more or less a similar thing. So the features of other systemic disease elsewhere,
Network is closed.
antibodies, etc., is what going to give you the diagnosis or the clue. With regards to said, often the most useful diagnostic test is actually kidney biopsy. After treating the acute illness, that is what most of the nephrologists will do. So you can decide about the prognosis because anti-GBM, I mean, just information really, anti-GBM disease, if somebody presents with the severe renal failure requiring dialysis, usually most of them do not recover renal function at all. Whereas ANCA, the prognosis is slightly better. Even if somebody presents with requiring stage for dialysis, they can recover renal function. But anti-GBM disease, unfortunately, that rarely happens. But that's again, that is why it's important to do the biopsy. Okay.
Okay,
So,
sir. Thank you.
So with regards to ANCA associated vasculitis, you know that the old-fashioned P and C ANCA, nowadays we prefer to do more specific testing, which is PR3 and MPO, as it usually will be positive in about 2/3 of the patients. Now, anti-GBM antibodies are a lot more specific and a lot more sensitive. So usually if you have an anti-GBM antibody positive in the correct clinical scenario, it's very unlikely it's going to be like a false positive or something like that. Rarely you can have a false positive ANCA, but anti-GBM, I haven't come across it or not come across in literature either, that you're going to have a false positive anti-GBM. So it does not, at least doesn't exist in clinical practice. Okay. And there are other causes, various other antibodies that you can check. So like you do an autoimmune profile. So for example, if somebody got an SLE, you will check ANA, double-stranded DNA, antiphospholipid syndrome, you will check anticardiolipin and the lupus antibodies and the other causes, as Jovan, Rowan, etc. But for most practical purposes, these things will only rarely, very rarely give you a pulmonary hemorrhage. So the top two differential, again, I'm repeating the same thing really, is ANCA positive vasculitis and anti-GPM disease. Okay.